Okay. Yep. So good afternoon, everybody. Welcome to the CME session being held by the Hong Kong Medical Association. I would like to thank the Hong Kong Medical Association for inviting me to give this talk, as well as to thank AstraZeneca for sponsoring today's event. My name is Dr. Herbert Leung. I'm a clinical associate professor at the Department of Clinical Oncology at COHK. And the topic for today is to address and discuss whether or not it is necessary to have lung cancer screening in Hong Kong. And these are my disclosures. Another important part of my disclosure is the fact that I'm currently a member of the Cancer Expert Working Group on cancer prevention and screening at the Department of Health at the HKSAR, and also the chair and core member of the Asia Pacific Coalition Against Lung Cancer. Now, the contents of my talk are really my own personal views and do not represent necessarily the positions of these two organizations. So let me begin, and maybe I could just set an introduction on lung cancer, given the fact that this is a CME talk for most of our clinicians here in Hong Kong who may or may not be seeing lung cancer patients routinely. Now, lung cancer certainly is the second most common type of cancer worldwide. As you can see from this pie chart, lung cancer ranks number 2. There are some situations where it's ranked number 1, and in actual fact, Hong Kong, it's ranked number 1, but internationally, it's number 2, with breast being the first, and then second, lung, and then third being colorectal, and the subsequent other histologies. I think most importantly is the fact that in terms of incidences of lung cancer within the Asia or Asia Pacific region, we have more than half, up to close to 60% of the incidences of lung cancer overall. And certainly this means that lung cancer is a very important disease in our locality. Now, in terms of being the second most common cancer, it is actually the most common cancer that leads to death worldwide. And if you look at the number of deaths in 2020 with lung cancer, accounted for 18% of all cancer-related deaths, and close to about 1.8 million people have died of lung cancer during that year. Certainly, again, this is a very large proportion being in Asia. Now, what we also know is in terms of lung cancer, it is commonly diagnosed at the relatively advanced stage. And this is often associated with patients having poor prognosis. On the bar graph here on the left, which is with the green bars, what you can see is the stage of presentation of these patients when they first come and consult medical advice. And certainly you could see up to about 41% of these patients are actually already at stage 4 disease and diagnosis. What we, of course, also know is the fact that if you do present at stage 4, the survival is certainly much more dismal than patients who are actually diagnosed and possibly treated at an earlier stage. And this is really a big difference between night and day. Patients who present with stage 4A or 4B disease, best 5-year survival is at about 10%. But of course, if you have early stage disease or even in situations of precancer, it is very much a curative situation. Now, specifically for Hong Kong, this is the deaths and crude death rate due to lung cancer over a period of about 30 years from 1981 to 2019. And you can see that throughout the years, in actual fact, the death rates have actually been gradually increasing. And the crude death rate for male and female was 77.4 and 33.8 per 100,000 population in regards to their male or female gender. Certainly, there is still a larger number of male patients who have lung cancer, but the proportion of female patients are actually something that we should be worried about as well. And lung cancer can, of course, occur in the younger age group, but generally speaking, we are talking about a slightly older age group of patients who are diagnosed with lung cancer and dying of lung cancer. You can see here that the peak really starts to kick up in the age of 65 and above. And certainly at the older age group, it is also an important aspect which can lead to death as well. And I think that's also important to think about, because when we think about lung cancer treatment, we also think about side effects and toxicities. We also have to think about whether or not these patients who are slightly in the older age group are necessarily fit for some of the aggressive treatments that we have. And if that's the case, maybe if we're able to diagnose them early, then they can be spared from having, say, the need to receive chemotherapy. Now, jumping into what the current Hong Kong government's recommendation is in terms of lung cancer screening, in actual fact, the published available data and the published guidelines was actually formed in 2016. So that was already some time ago. And based on the recommendation at that time, still currently on the CHP website, is that for lung cancer screening for both men and women in the general population or in patients who are considered high risk, in actual fact, routine screening for lung cancer with chest X-ray or sputum cytology is actually not recommended. And based on the available guideline that's published again on the Department of Health homepage, there's insufficient evidence to recommend for or against lung cancer screening by low-dose CT in asymptomatic patients or for mass screening. Now, this is actually a snippet of one of the recommendation documents that was published by The Economist about 2 years ago, which actually looked at lung cancer screening as well as treatment strategies within the Asia-Pacific region. And what they did was surveyed the physicians in each of the localities as well as government officials. And what they've decided and what they've realized is the fact that in terms of a strategic priority of having lung cancer as something that the government as well as the population is to be focused on, Hong Kong ranks relatively poorly compared with its Asia-Pacific neighbors. We have been considered having moderately low strategic priority for lung cancer screening and treatment. And we fare actually even worse than Indonesia, whereas some of the other developed economies, including, say, Japan, Australia, and even in mainland China, these are considered high priorities. So I think there's definitely space and room for us in Hong Kong to improve our strategies in terms of early diagnosis as well as treatment of lung cancer. Now, going back to our medical school days, you would recall in the community medicine public health lecture that we may or may not have skipped during our medical school days, there are some specific characteristics that make a disease that's worthwhile to screen for. And this is based on the Wilson and Jungner's principle of screening, where the condition which satisfy most of these 10 criteria are potentially diseases that's worth screening. Now, if you recall, the condition should be an important health problem, and certainly lung cancer is. There should be accepted treatments for patients with recognized disease. Definitely in lung cancer, we have multiple modality treatments, including surgery, radiation, chemotherapy, etc. There should be facilities for diagnosis, and treatment should be available. And certainly, I think Hong Kong is not shy of that. There should be a recognizable latent or early symptomatic phase. I think this is the main crux of the issue of lung cancer, because most of the time when they do present with symptoms, they are actually of late stage. So we must be able to try to find a recognizable latent or early symptomatic phase through screening. There should be a suitable test or examination, and I will go into more details about the use of low-dose CT. The test should be acceptable to the population. The natural history of the condition should be well understood, and there should be an agreed policy on whom to treat as patients. The cost of case finding, including a diagnosis and treatment of patients diagnosed, should be economically balanced in relation to possible expenditure on medical care as a whole. And therefore, it is important for us to do some quantitative as well as qualitative research in terms of cost effectiveness of, say, rolling out a screening program. Case finding should be a continuous process and not a once for all project. So I would say, based on the available information, not even work that we're about to begin, I think lung cancer probably already satisfies 7 or 8 out of 10 of these criteria. And certainly what we're doing, and I will explain in the coming minutes, is some of the initiatives to make sure that lung cancer satisfy all 10 of these criteria. Now, going back to lung cancer screening, and previously, prior technologies, including chest X-ray and sputum cytology, really have not been all that useful. But currently, the bedstone of essentially lung cancer screening is the use of low-dose CT, and low-dose CT is a non-invasive procedure that delivers more detailed images than chest X-ray, allowing a rapid acquisition of a large volume of data. In prior clinical trials, we've shown that low-dose CT has high sensitivity as well as acceptable specificity for the detection of lung cancer in high-risk populations. And this is able to translate to a reduction in lung cancer mortality. Whereas in contrast, unfortunately, with chest X-ray, we have not been able to establish this. Now, what we do know is that screening does help identify lung cancer at an early or potentially curable stage before the symptoms appear. And this is based on multiple studies around the world, including these three main pillar studies that were conducted initially and mainly in the Western population. Now, the NLST trial is a large clinical trial that was based in the United States, which showed that screening with the use of low-dose CT reduces mortality from lung cancer significantly compared with chest X-ray. You may have also heard of the Nelson trial, which is actually a European trial based in the Netherlands as well as Belgium, where actually it showed that lung cancer mortality has been able to be significantly reduced with low-dose CT compared with situations where there's no screening. And there's also the MILD study, which is specifically based in Italy, which showed that prolonged low-dose CT screening beyond 5 years have been able to enhance the benefit of early detection and achieves a significant mortality reduction at 10 years. Now, the goal of screening really is to increase early detection and the ability for them to intervene at a localized stage of disease in a high-risk population, for example, the use of surgery, and we'll be able to then have a curative approach for these patients. Screening can, of course, can also provide benefits beyond lung cancer detection. For example, there could be incidental findings of, say, coronary artery calcification on your low-dose CT, and they could be rapidly referred to cardiologists as well as family physicians to modify their cardiac risks. COPD detection in the smoking population, as well as using this as a smoking cessation opportunity. So I think with any screening program, if it is built well and robust, there are actually many benefits aside from actually trying to catch the disease in question. Now, if you think about some of the common risk factors for lung cancer, of course, in the center of all this is tobacco, smoking, and that has always been the pillar of the risk factors that's being considered, at least the decision on what is considered to be high-risk populations. But I think it's also important for us to remember, especially nowadays where we have actually more in-depth look at the molecular characteristics of lung cancer, we realize that not only tobacco is a risk factor, and there are many other risk factors that come into play, including, say, environmental exposure, such as radon, which is an issue in Hong Kong, as well as the use of cooking fumes in our population. Occupational exposure, of course, we already well know that asbestos plays a role, although, of course, the use of asbestos have fallen out of favor. COPD continues to be one of the issues that causes lung cancer, as well as infections such as tuberculosis and pneumonia. Now, specifically, though, I do want to focus on the issue of family history, and we'll be talking a little bit more about that in the coming slides, as well as the issue of secondhand smoke. Now, going back to the three studies, which I actually highlighted earlier on, including the NLST that was based in the United States, Nelson that was based in the Netherlands, as well as Belgium, and the MILD study that was based in Italy. These were actually some of the eligibility criteria for recruitment of subjects into these screening programs. And you can see that there are similarities between all these three studies, where it is a slightly older population from 50, 55 onwards to 75. Smoking, again, is the main pillar of risk. And certainly for the people who were recruited into these studies, they were all either current or former smokers. There were also allowances for subjects who have quitted smoking. But again, just to emphasize the fact that at least in the Western clinical trials of screening, smoking was the main culprit in terms of possible causation of lung cancer. Now, without going into too much details, what they found in all these three studies is the fact that for the use of low-dose CT, there is actually a positive correlation for decrease in mortality. And you can see that these forest plots are all on the left, favoring the use of low-dose CT. The hazard ratio is somewhere in the range of 0.61 to 0.8 with a robust confidence intervals as well. And I think these are the clinical trials which actually led to the validation of the use of low-dose CT and a screening program for lung cancer. And I think it's also very important for us to remember that when we are screening for lung cancer, looking or being able to find and diagnose early lung cancer is not really the endpoint. What you really need to do is to show that by able to find these lesions and be able to treat these patients early, we're actually having an impact on survival and mortality. Now, going into each of these clinical trials very briefly, and that would give you some idea as to how these lung cancer screening trials were actually conducted. The NLST trial is the one based in the United States, which is an annual lung cancer screening with low-dose CT versus chest X-ray in high-risk patients or subjects. These, of course, are as defined here in the green box on the left, where they have to have history of cigarette smoking of more than or equal to 30 years. Now, two groups randomized either to have 3 annual low-dose CTs, so once a year for 3 years, or just chest X-ray once a year for 3 years. And what they've decided was the primary endpoint being lung cancer mortality and secondary endpoint being these here, also in the box. And what they found was that in patients who actually were randomized into low-dose CT group, they were able to show that there was a 20% relative reduction in lung cancer-related mortality. And specifically, the patients who were diagnosed with lung cancer based on low-dose CT, about 63% of these patients were of stage 1, and the majority of them were actually stage 1A. So stage 1A are essentially patients with lung nodules which are smaller than 2 centimeters in size. The Nelson study, the one that was done again in the Netherlands and Belgium, it follows a somewhat similar design, but what they have done was to have 4 different low-dose CT screenings at baseline, and then at 1 year, 3 year, and 5.5 years versus no screening. And the primary outcome was lung cancer mortality. And these are the results of the Nelson study, looking at high-risk male population specifically here. And what you can see is the fact that, again, in the screening arm, there is a larger number of patients that were picked up at an earlier stage disease, especially in stage 1A and 1B. And in actual fact, looking at the lung cancer mortality rate ratio throughout the years, even after this, the conduct of the screening at year 8, year 9, and year 10, we're continuing to see an improvement in the lung cancer mortality ratio in the people who actually were randomized into the low-dose CT arm, as opposed to the no screening arm at all. Now, essentially, based on these data, it's always data from each of these jurisdictions, which actually may have conducted smaller scale clinical trials. Lung cancer screening programs around the world is being rolled out or already well established. Of course, being the location where these trials were conducted, we have the US and Italy, Belgium, for example, as well as France. But other jurisdictions have also rolled out various different programs. I will be focusing a bit more in Taiwan a little later because they are actually the leader of lung cancer screening within the Asia Pacific region. But certainly, I think what is missing here is Hong Kong. And if we think about what are some of the potential benefits and harms of lung cancer screening and early detection, this is based on the United States Preventive Service Task Force, which really is the thought leader in terms of establishment of early diagnosis and screening and prevention. And after looking through all the data, their recommendation is the fact that there is adequate evidence of low-dose CT in terms of sensitivity and specificity to detect early stage lung cancer. The use of low-dose CT or annual screening can prevent a substantial number of lung cancer-related deaths. There are potential harms, of course, including false positive results, which leads to unnecessary tests or invasive procedures. and also a short-term increase in distress when the situations are indeterminate, overdiagnosis, as well as potential radiation exposure because of the use of low-dose CT. But what they found was that there is adequate evidence that the harms of screening for lung cancer with low-dose CT are actually moderate only in magnitude. And the assessment is the fact that with moderate certainty, the annual screening for lung cancer with low-dose CT is of moderate net benefit, especially in patients who have high risk based on age, total cumulative exposure of tobacco smoke, as well as years since quitting smoking. Now, these recommendations are important for the US population, and that's why screening is rolled out in parts of the US. Whether or not this necessarily applies to Hong Kong is something that we can continue to debate. Now, all the studies that have been done, or at least that have been described previously, were based in the West. What we do know is that lung cancer in Asia is actually somewhat different. We also have slightly different risk factors, as well as slightly different characteristics. This is actually a picture that was borrowed from a publication that was just published by Dr. David Lam from the University of Hong Kong, which is a Pan-Asian consensus on the use of screening for lung cancer. And what we do know is the fact that the age of onset for lung cancer in the Asian population seems to be younger than Caucasians. Prevalence is the fact that females continue to be smaller than males, but a very important aspect of lung cancer. And what we found is that in females, more than 50% of patients who are diagnosed with lung cancer are actually non-smokers. There's actually increasing evidence of air pollution, including PM 2.5, being one of the main drivers of potentially leading to lung cancer. And this specifically is in the Asian population. And there have actually just been some publications as well as research looking at the correlation between EGFR, positive non-small cell lung cancer, and the exposure to PM 2.5 and Asian genetics. We will have more results of that coming up shortly. Of course, there are also other exposures and other risk factors, which are again similar to the West, but just to highlight the fact that in Asia, we are dealing with a slightly different issue. And what you can see is, and I've described earlier on, that Asia actually has the highest burden of lung cancer in the world. And this graph, I think, really just depicts the situation where if you look at the percentage of new lung cancer cases, as well as deaths from lung cancer, we are actually the leader of the pack from other jurisdictions and other regions around the world. Now, again, in lung cancer being the main cause of death in 2020 for males in East Asia, and also actually in females in East Asia, lung cancer also supersedes the death rate due to breast cancer. Now, what's interesting is the fact that the smoking prevalence of lung cancer patients in East Asia as compared to Western countries are essentially quite different. What we have here, Europe and USA, in actual fact, the majority of lung cancer patients, both females and males, are actually smokers. But here we have information from, say, Hong Kong, where only about 28.3% of female lung cancer patients are smokers, which means that the remaining 72% are actually patients who are non-smokers. And this is actually shared in terms of its distribution around the Asia-Pacific region. Males, certainly there is a much larger smoking male population, so we could still see the majority of male lung cancers are smokers. And in actual fact, the estimated lung cancer in never smokers around the entire Asia-Pacific region, accounting for both male and female, is 34%. Now, there are some key elements for a successful lung cancer screening and how we can implement it. I think we have to recognize the fact that there are specific regional differences of lung cancer epidemiology and resources. I think we have to think about how we can improve lung cancer survival. And if we use the criteria that were set up by the three main studies that I've described earlier, where smoking is the main issue, a third of lung cancer patients within our locality will not be screened. So what we need to do is to make sure we establish a cost-effective lung cancer screening program in never smokers. We must have key elements of a successful implementation of such a screening program. And this is where I bring on the example of Taiwan, where they have just rolled out recently nationwide lung cancer screening. Now, all this really started with one of the most robust lung cancer screening trials that were conducted, and certainly probably the leading trial in the Asia Pacific region. This is known as the TALENT trial, which is the Taiwan Lung Cancer Screening in Never Smoker trial. And in this trial, it was actually conducted over a period of 4.5 years between 17 different medical centers distributed throughout the island of Taiwan, where non-smoking individuals aged between 55 to 75 with lung cancer risks based on these risk factors here in this table were actually initially given a chest X-ray first. And with the chest X-ray, of course, if it was positive, then they will go on to a standard investigation where they would then actually do a biopsy and then follow up. In situations where the chest X-ray was negative, they would then do a low-dose chest CT, as well as having extra research, including look at some potential blood as well as urine biomarkers, and then if positive, then do a biopsy or follow-up. Now, I think what's most important is the inclusion criteria that's been used in the TALENT study. And you can see here on the left, family history of lung cancer is definitely one of the important risk factors, which we believe is specific to the Asia Pacific population. There are, of course, other risk factors, including, say, environmental or tobacco use, other chronic lung disease. Cooking index is something that's very important. There have already been long standing studies establishing the issues of cooking fumes, use of cooking oils, and the fumes that's generated, especially in the way that we cook in Asia, which is associated with this, and as well as people who are cooking without the use of ventilation. Now, it's very important and very interesting how they've actually did put in a chest X-ray prior to the randomization of using CT. And that may be one of the ways of actually reducing costs to screening, because of course, if there's already a lesion in the chest X-ray, there's probably no need to go ahead to do low-dose CT screening. Now, these are the results of the TALENT study that was presented by Professor Yang, who is the principal investigator of the TALENT study group. And what they found, and T0, meaning the first time that, or the baseline CT or low-dose CT that was done, the cancer detection rate of that high-risk population was 318 patients out of a population of 12,000. And this has a screening rate, positive rate of 2.65%, which actually is more than double of what we found in the well-established screening programs based on NLST or the Nelson study that I described earlier. Within this group, about 257 or 2.14% of them was invasive lung cancer, remaining being earlier precancerous lesions. Now, in the low-dose CT being positive, 17.4%, and then subsequently they went on to do a lung biopsy or surgery, 3.36%, and lung cancer diagnosis was confirmed being very early stage in 96.5% of the people who were confirmed to have lung cancer. The prevalence of lung cancer with or without family history is 3.29% versus 2.02%, and 60 or 20% of these patients actually had multiple primary lung cancers. And I think, again, this is a very interesting situation within the Asia Pacific region. Now, multiple primary lung cancers is something that we also see in our clinical practice, where patients actually have more than one lesion, so maybe 2 or 3 lesions, different lobes, a different side of the lung. Previously, you would consider these potentially metastatic disease, but in actual fact, because of the fact that we are able to do specific molecular genomics, we're able to identify the fact that they may actually carry different genomic markers. And in actual fact, this patient, for example, is suffering from two different stage 1 lung cancers, which prognostically is very different than labeling her as a stage 4 non-small cell lung cancer. Now, family history seems to be a very strong association in terms of risk of development of lung cancer. These are the tables of two graphs looking at the number of degrees of relatives in the x-axis and the lung cancer detection rate. And certainly if you have more than or equal to 3 of your first degree relatives having a diagnosis of lung cancer, the chance of us being able to detect lung cancer during the baseline screening is much higher. And if we compare the results of the TALENT study, which actually looks again at the non-smoking high-risk population versus the Western data that was published previously, we could see that in such a population, the baseline CT detection rate seems to be even higher, with 3.2% in patients with family history. Without family history, who are never or light smokers, being 2% or 2.6% in ex-smokers. These are the positive predictive and negative predictive values, and certainly these are actually very favorable when compared to other studies as well, with the majority of the patients being able to be picked out at a very early stage. And these are slides that's been shared to me by Professor Yang, looking at the different time points throughout the last 20 or 30 years, where in actual fact, the lung cancer mortality rate in Taiwan has actually decreased. And it is important for us to remember that, of course, lung cancer screening is something that we're talking about today, but the whole purpose and the whole premise of all this really is to improve lung cancer outcome. And not only is it important for us to screen for early stage lung cancer, but there should be a multi-pronged approach looking at how we could eliminate some of the risk factors as well as in patients, say, with advanced disease, whether or not there are effective treatments where we can actually prolong their survival. And all this actually is a package for us to improve the outcomes of people with lung cancer. Now, in this particular graph, you can see that throughout the years, there have been different time points in the healthcare system in Taiwan, which may have actually affected the outcome of lung cancer patients. For example, in the 1997 or so era, there have been a big push for anti-smoking campaign. Subsequently, in the year 2004, one of the tyrosine kinase inhibitors for EGFR, known as gefitinib or Iressa, was reimbursed by the government. And then subsequently, another one, erlotinib or Tarceva, was also reimbursed. And these actually contributed to the prolonged survival of advanced stage lung cancer patients. Now, with the use of low-dose CT establishing its use through the TALENT study, it does appear that in actual fact, the age-adjusted rate of lung cancer mortality continues to decline, and also subsequently reimbursement of some of the immunotherapies for both advanced disease as well as for early stage disease. And there's a prediction that if we are able to continue this improvement in terms of survival and a multi-pronged approach, we are hopefully able to reach a reduction in lung cancer mortality. And certainly, if we actually are able to reduce it, say, by 2.4% every year, looking hopefully in the year 2035, that's in about 15 years' time, we'll be able to reach a 30% reduction in lung cancer mortality. And of course, the stronger we push in terms of being able to reduce mortality annually, we are hopefully being able to push forward the time when we are able to have significant reduction in lung cancer mortalities. And at the end of the day, when we're looking at, again, reduction in lung cancer mortality, screening, it is a multi-pronged approach. And when we're looking at screening, for example, we hope that by doing all this, we'd be able to have a higher number of lung cancer patients, if they're diagnosed, to be diagnosed at an earlier stage. We'll have then a higher 5-year relative survival. And when we're doing screening, we are talking about, for example, today, the issue of low-dose CT, how we manage incidental nodules, which I'll talk about briefly a little later. But with new technology, we're also thinking about the use of, say, artificial intelligence to help us read some of these CTs, to streamline some of our workflow, the use of radiomics, or as well as possibly even serum markers to use as a companion diagnostic together with low-dose CT, which hopefully be able to give us a better positive predictive value, as well as the robustness of any screening program. Now, I flashed this slide previously, and I just want to highlight on some of the issues in terms of harms of early detection and intervention and treatment. And one of the issues of any screening program is the possibility of having false positives. And if you look at the false positive rates compared with lung cancer screening, it's actually very similar with other widely used widely used cancer screening procedures. For example, in the NLST, we're talking about a 12.8% false positive rate in the baseline scan. The Nelson study quoted 1.2%, but if we look at breast cancer, the real-world mammography data, a false positive is somewhere in the range of about 10 to 15%. Overdiagnosis based on the two prior trials, including the NLST and the Nelson trial, was also relatively low when compared with breast cancer. One of the biggest concerns of the population, subjects, patients, or even doctors is the risk of, say, radiation exposure. And it's important for us to remember that in actual fact, a low-dose CT, the amount of radiation is about 1 to 1.5 millisieverts, which is actually very similar to a chest X-ray. If something that I think is definitely worth trying to change the mindset of some of our population. Now, of course, we want to minimize the radiation exposure as much as possible, and maybe 1 to 1.5 millisieverts is already more than what we really want. Then we have to think about how we could strategize in terms of the frequency of these screening. Do we necessarily need to do it every year? Can we do it once every 2 years? Are there better risk stratifications where high-risk people are screened even more frequently and low-risk but moderate-risk people are screened less frequently? I think that's where we are moving towards in terms of our studies and our designs for lung cancer screening programs. Now, again, in terms of the number needed to screen, so the number of people who have to go through screening procedures to pick out a cancer or really to impact mortality for lung cancer, in actual fact, it is relatively low compared to other cancers, just because of the fact that lung cancer can happen in both males and females. Lung cancer is also a global problem of high proportions. So the amount of investment that you need to put in order to pick out a positive case is relatively low. And certainly if we already have established screening programs for colon, breast, as well as cervical cancer, there's no reason why we shouldn't be doing it for lung cancer. Now, I'm not going to go into details about this, but just suffice to say that there are situations, of course, where the screening CT comes back to be indeterminate, where you're unable to identify whether or not they necessarily have or do not have lung cancer, or whether or not at that particular juncture it is worthwhile to go on to do biopsies, or whether or not there is a role to observe and repeat a scan later. It's suffice to say that in actual fact, there are different guidelines on how to manage these nodules, and there are specific nodule clinics that potentially patients can be referred to, where we have dedicated physician and team being able to monitor these. And I think it's very important that these are well accepted by the screening community so that we know how to triage some of these indeterminate nodules. One such guideline which is commonly used is called the Fleischner Society guideline that was published in 2017, where, again, it actually identifies the nodules based on the size, as well as whether or not it is a solid inconsistency or subsolid inconsistency, and labels them at various different risks. And there are specific recommendations as to whether or not they should be screened more frequently, whether or not there's actually no need for routine follow-up, and when they should or should not proceed to have a biopsy. So I think it's important for us to remember that there are these guidelines in place, and any screening program should have appropriate guidelines as well. So lastly, before I close, I just want to highlight to you some of the ongoing initiatives for the promotion of lung cancer screening, which is happening globally, as well as in the Asia Pacific region, as well as also stemming from Hong Kong. And all this actually builds upon each other. There have been efforts that are spearheaded globally, which we're trying to adopt in Asia and Hong Kong. We've also had some efforts spearheaded in Hong Kong, which is also being looked at globally as well. Now, this is just a snapshot of some of the things that's been happening. This is a lung cancer policy network, which is part of the Lung Ambition Alliance. There is multi-country, multinational representation, including China as well as Hong Kong. And our colleagues from the University of Hong Kong, including Dr. David Lam, is actually one of the key members of this particular organization. Specifically more in the regional aspect, we've also just recently formed the Asia Pacific Coalition Against Lung Cancer, where I'm actually one of the executive core team members together with my colleagues around the Asia Pacific region, with the aim of trying to effect implementation and drive policy changes for lung cancer screening. More locally, we have experts from around the region or around our city, multiple disciplines, including thoracic surgeons, respiratory physicians, oncologists, radiologists, as well as public health experts, where we are now trying to formulate a screening expert panel to try to advise the government on how we can actually roll out lung cancer screening. One of the main and important publications that was just published by Dr. David Lam together with his colleagues within the Asia Pacific region that's being adopted internationally really is an expert consensus report on lung cancer screening in Asia. I would like to defer you to take a look at that document, which is available for free online in the Journal of Thoracic Oncology. Moving forward, in actual fact, myself, together with our colleagues at Hong Kong U, as well as some of the investigators in the Netherlands, have actually looked at the cost effectiveness of doing low-dose CT and lung cancer screening in Hong Kong based on Hong Kong healthcare costs, Hong Kong local molecular epidemiology. That data actually has been accepted for presentation at the World Congress in Lung Cancer in September this year, and after which we'll be able to share with you some of these important results. Suffice to say that we found the use of lung cancer screening to be quite cost effective if it is to be rolled out in Hong Kong. Before I end though, it's very easy for me to paint a really rosy picture of how and why we should do lung cancer screening, because of course we are able to diagnose lung cancer early. We're also able to have significant improvements in survival. But it's easy for me to say all this. It's what's most difficult is to be able to make sure that we have the proper pieces of the puzzle all lined up as well. And we must make sure that we have an established infrastructure and logistics for screening. The question, for example, and specifically in Hong Kong, is who should take charge of lung cancer screening? Should it be the hospital authority? And they would probably also tell you that in actual fact, we deal with patients. Most of the population are not patients, they're healthy individuals. So therefore, we are not necessarily going to be involved. The Department of Health or Center of Health Protection seems to be the logical group to be able to spearhead this, but do they actually have the capacity or the resources to roll out such a large infrastructure? At the end of the day, with these large screening programs and the high demand for, say, imaging, as well as follow-up, whether or not there is actually a position for private or public partnership. The bottom line, of course, is who pays for all this and what are some of the incentives to actually have subjects go and screen. So you could roll out a beautiful program, but are the population at risk really going to go if there is no buy-in from their side as well? Are we able to, say, provide some sort of healthcare vouchers for them, potentially even tax rebates for you going to do a screening, then therefore you get some tax refund, or maybe even in the era of using insurance, whether or not there could be deductions in their premiums if they actually went on to do actually a screening program. So what we really do need is to have a referral pathway as well as guidelines for incidental findings and monitoring. And as highlighted previously, in situations where you say find ischemic heart disease or coronary heart disease or other issues as picked up on the lung cancer screening, how are we going to deal with that? Who are we going to refer to? These are most important. And lastly, all this about screening is very important, but at the end of the day, also the most important or another very important key aspect to reduction of mortality is to reduce the presence of lung cancer to begin with. And what is easiest is that we should make sure that smoking cessation continues to be one of the main pillars that we should be championing, and we should take advantage of using a lung cancer screening program to also advocate smoking cessation, as well as the importance of doing education. The decision to begin screening should be a result of a thorough discussion of benefits, limitations, as well as known and uncertain risks. So here, back to this original slide, Hong Kong's current recommendation. This is based in 2016, where there is insufficient evidence to recommend for or against the use of lung cancer screening. Now, in actual fact, the Cancer Expert Working Group have already formulated a draft document in 2022, looking at revising the plan for lung cancer screening in Hong Kong. It is currently still a restricted document where I'm unable to share. We're still hoping to gain insight from other stakeholders, as well as the analysis of some of the evidence that's been established more regionally. I think it is suffice to say, though, that we will have hopefully stratified recommendations based on risks, and there should be specific guidance for asymptomatic persons who have increased risks. And hopefully we'll be able to roll out this document soon, and then be able to form the initial seed or framework where we could then have hopefully a favorable screening program for us in Hong Kong. So with this, I'd like to end. I'd like to thank you for your attention and for spending the last 45 minutes with me. I'm happy to take on any questions that you might have. Please feel free to type it into the Q&A box. So thank you very much. Okay, so there's some questions here. Let me see if I could go through them one by one. Okay, let me just pull them up. Okay, we have a question from Dr. Chan. Lung cancer versus, colorectal cancer, which one has higher genetic loading? Why Asians have a higher chance to have lung cancer than Caucasians because of cooking fumes? That's a very good question. Now, we don't really know. I don't think there's a clear comparison between lung cancer and colorectal cancer. Of course, the risk factors for colorectal cancer, of course, family history is also very important. The change to a Western diet, processed meats, the effect it has on the gut microbiome and risk factors, etc. For lung cancer, though, specifically, I would say it has a more genetic association, given the fact that we do see lung cancer within the East Asians or even within the Chinese population, molecularly are different from the Western population. I've mentioned earlier that, for example, in our non-smoking females, EGFR lung cancer accounts for about 40 to even now close to 50%. And that is genetically associated with, say, family history. It is also genetically predisposed, at least that's what's believed right now, where because of some sort of Asian genomics, the exposure to then PM 2.5 actually is a precursor to development of EGFR positive lung cancer. Cooking fumes is something that has been well established through population studies. I remember as a medical student, we were looking at some of the publications from back then, even 10 or 20 years ago back then, may be associated with similar things, but I think it also has to do with some of the genomics of our population as well. Okay, and for Dr. Butt's question, if a patient has symptoms suspicious of lung cancer, do you recommend a low-dose CT scan? I would say that for somebody who actually already has symptoms, I would not recommend a low-dose CT scan necessarily. I would certainly refer them for a workup, and if anything, maybe even a full CT scan. I think the purpose of the low-dose CT scan really is to pick out a high-risk population, which is asymptomatic. And in people who are potentially symptomatic, you do may require a full CT scan to really take a look. The difference, of course, between a low-dose CT and a full CT with contrast is the fact that you're able to delineate the lymph nodes a lot better with a contrast-based CT. So for any coin lesions within the lung parenchyma, I think a low-dose CT is just as good, but for proper staging, you do need a full CT scan to see the lymph node status. Would we combine two different kinds of targeted therapy to treat lung cancer? A question from Dr. Chan. Potentially, yes, but I think it depends on what kinds we're combining. Many a times, in actual fact, we believe that having one particular molecular driver is most lung cancers actually have one particular molecular driver only. But in actual fact, what we're seeing is at the time of resistance to treatment, they can have several molecular alterations. And we are seeing more and more situations where there may be a need for us to combine targeted therapy treatments. Dr. Tam's asking, as patients may get whole body MRI as a general screening exam, do you think it's useful to screen for lung cancer? Would you recommend additional low-dose CT? Okay. I think it's important for us to remember that all this talk about low-dose CT is based on risk stratification. So for people who are potentially at risk of developing lung cancer. Now, if somebody who's already gotten a whole body MRI because of health check reasons, no particular risk factors, maybe that's already enough. Certainly the resolution of a whole body MRI looking at the lung parenchyma may not be as good as a low-dose CT, but to then add on a low-dose CT where there is amount of radiation exposure, although it is relatively low, I'm not quite sure whether or not it really adds much value. So I think instead of recommending everybody to get a low-dose CT, what is most important is for us to identify who these at-risk individuals are and to recommend accordingly. Have you any comment on the use of ctDNA for cancer screening? In actual fact, this is currently being investigated. There are actually some commercial companies already starting some of this, but specifically for specific types of cancer. You may, of course, have heard of some of the new technologies that's being launched in the recent 1 or 2 weeks. There have been some big funding with collaborations between, say, Professor Dennis Lowe and other companies. But right now for cancer screening, it is not prime time and it's still investigational. How much radiation is low-dose CT compared with chest X-ray? The question, I think, is somewhere in the range of, say, 1 to 2. So there have been some descriptions where a low-dose CT is the same amount of radiation, so 1 to 1.5 millisieverts compared to a chest X-ray. There have also been some descriptions previously where it's about 2 chest X-rays. Certainly, it does not impose a much bigger risk than taking a chest X-ray, but much more effective. How effective are serum markers in lung cancer screening? Not effective presently in primary care, and not even only primary care, and all care. In actual fact, there are no good, robust serum biomarkers to identify lung cancer, and it does seem as though that a low-dose CT is the best way of screening. Is there a role for traditional diagnostic CT with contrast if low-dose CT is borderline or positive? Yes, I think it depends on why it is borderline or positive. Now, of course, if it is positive, then we do normally will require a full CT or even a PET CT, mainly because of the staging purposes of looking at the lymph nodes. But for diagnosis, you will also require histology, either through a bronchoscopy or a CT-guided biopsy. And all these things would come into play for us to be able to establish the diagnosis and properly stage. What is the role of pro-GRP as screening tool? I'm not quite familiar with what pro-GRP is, so I'm unable to answer that question. Would you recommend an elderly with no risk factors to have low-dose CT if one can afford it? I would not recommend it. I would still think that the first step really is to identify who the at-risk people are and to screen those. Because, of course, the flip side is if they are elderly but do not have any risk factors, you may also run into a lot of incidental findings, which can lead to stress and unnecessary investigations. So we have some other questions, different relevance. How much more radiation is low-dose CT compared with full CT? Actually, within the slides, which you'll have a copy of later, there was a table and a graph showing the amount of radiation. I can't quite recall exactly how compared with CT, but with a PET CT is about 20 to 22 millisieverts, whereas a low-dose CT is about 1.5. What is the chance of raised CEA for lung adenocarcinoma? Yes, CEA is often used as a tumor marker for adenocarcinoma, but not all adenocarcinomas of lung actually have raised CEA. I don't actually know the actual percentage, but I would say maybe about 50 to 60%. So I would probably think that it's not a good idea to just use CEA as a screening tool. Certainly, we use CEA a lot in patients who have established lung cancer, and we're trying to follow them throughout their treatment journey. Okay, so I think I've tried to answer all the questions or most of the questions that have been posed. Certainly, if you have any further questions, you're more than welcome to email me or send us information. Lucky for you, there are 10 Q&A questions for you to answer, for you to gain your CME, and hopefully you'll be able to answer them today. And also hopefully I was able to give you adequate information for you to answer them correctly. So with this, thank you very much. I think it probably is time to close, and thank you very much for joining today.